Tēnā koutou katoa. This presentation is going to talk about the COVID-19 response in Aotearoa, New Zealand, and some of the key principles for population health. So I have had considerable experience in previous pandemics. In fact, they changed my working life. I got interested in public health medicine when I had a spell in the late 80s working in the Minister of Health's office in Parliament, and that was when the HIV/AIDS epidemic was really peaking, and the Minister was concerned about the potential for HIV to be transmitted in injecting drug users because there had been explosive outbreaks overseas, and I set up the National Needle Exchange Program, and that got me very interested in public health. And really I switched from clinical medicine at that point to pursuing a career in this field. I remember SARS in 2003, the first global coronavirus pandemic, which turned out to be relatively manageable, and then pandemic influenza H1N1 in 2009, which was relatively mild from an influenza pandemic point of view, and then of course COVID-19 in 2020, which I don't think any of us were prepared for. So today I'm going to go through 10 public health questions, and these are designed to really illustrate some of the approaches to infectious disease management. And in each instance, I'm hoping you can pause for a moment and think about how you would approach the question that we're talking about. So, sizing up pandemics, the core idea is epidemic, which is more than expected. You can have outbreaks which are localized in time and place and are usually relatively manageable, and very rarely they become pandemics where they are epidemics that affect multiple countries. So the first question, what are the most important pieces of information you need to size up a new pandemic threat? I want you to think about your top three and just pause for a moment and write them down. So when we think about pandemics, and this graphic is showing really some of the huge pandemics that have changed the world historically, and there's a remarkable line here around 1870 when there was a new theory that really was contentious initially and became accepted wisdom over the next 2 or 3 decades around that period, and that's the germ theory. And prior to that, anything was possible because people didn't really know that there were such things as microbes. And of course after that we had the pandemic influenza in 1918, which was huge, and of course more recently HIV/AIDS and a range of other smaller flu pandemics, and of course COVID-19 more recently. So the things that you want to know about a pandemic when you're sizing it up: how transmissible, how severe, how controllable, and also your level of certainty of that knowledge. And this is really critical knowledge to have. So we've got new techniques now, such as whole genome sequencing, which tell us a lot of new information about the behavior, particularly of viruses, but also bacteria. And this was showing, based on the first introductions of SARS-CoV-2 into New Zealand, that among other things, only about 1 in 5 cases actually resulted in much onward transmission. It also showed us we had lineages from all over the globe at this stage in the early part of the pandemic. So a second question, choosing a response strategy. What are the main strategic options for responding to a pandemic? And aim for, again, write down your 3 major choices. And the options really are basically elimination and various forms of control, suppression or mitigation. So that gives you 3 broad choices. And so this is showing really at a strategic level you've got limited options. So in general, we try and control things. I mean, some things are too trivial to be concerned about, but generally we're trying to control pandemic threats to minimize the harm. We do this for most serious infectious diseases. Usually we're looking at suppressing to get the lowest possible rates. We do this still with TB and HIV/AIDS. But sometimes we use mitigation, and this is where there's a huge pandemic wave that's threatening to overwhelm the health system, like pandemic influenza, and that's been the global strategy for several decades. But if we can, we'd obviously suppress it. But elimination has a well-established system or approach for measles and polio and other diseases, and you can occasionally fully eradicate a disease at the global level, as has been achieved for smallpox. But this had not been used for pandemic disease before COVID-19. So basically New Zealand committed to this on the 23rd of March with the decision to pursue a rapid lockdown with only 100 cases and no deaths at that stage. So we wrote what I think is the world's first published elimination strategy. We were writing it at that point. We were advocating strongly for it. And this was published in the next issue of the New Zealand Medical Journal. So one of the things about strategies is changing them as circumstances change. We had elimination for about or over 18 months. We had a period of suppression for the Delta outbreak, and then with Omicron becoming widespread, we switched to a mitigation strategy to try and reduce the harm. So in choosing interventions, one of the tools we have for summarizing the behavior or the transmissibility of a virus or any agent really is the reproduction number. So just think about what that idea means, reproduction number. Why is it important to reduce this number to less than 1? And what are the broad types of interventions to reduce the reproduction number? So basically, the basic reproduction number only applies at the start of an outbreak or a pandemic when there are not many infected people. And this is the average number of infections generated by one case in a population where everyone's susceptible. But later on, when a large portion of the population are immune to some extent from vaccines or infection, you're talking about the effective reproduction or the reproduction number at time t. Now, if this reproduction number is over 1 at any point, you have exponential increase. And for example, if it's 4, 4 cases go to 8 and 16 and so on. So that results in an explosive outbreak. So the reproduction number is not a fixed quantity, it's a function of the interaction of the organism in a host and in a particular environment. And there are these three things, these three numbers that contribute to it: how transmissible, what the contact rate is, and the duration of infectivity. So all of your interventions are really trying to reduce these different components. And things like physical distancing obviously reduces transmission and contact rates. Things like vaccination alter all of these parameters and can bring down the reproduction number. So the elimination strategy involved excluding cases, keep it out of the borders, stamp it out, that's case and outbreak management, and trying to turn down community transmission with a range of measures, and also a social safety net to support people who became very vulnerable during the pandemic. So this is one of the most remarkable graphs generated during the time of the pandemic. This is the number of people coming across the border in New Zealand, reducing from about 25,000 a day down to maybe 500 a day. So a massive reduction. With a brief period of opening up to Australia with a green zone, and then as controls came off, we started to return to now pre-pandemic levels of travel. An intervention that applied only for a period was this high volume testing as part of contact tracing. and we were getting up to peaking at 40,000 tests a day, which did involve pooling of specimens to make this more efficient. And also something else that is now almost a historic relic is the alert level system, which functioned very well, I think, as a way of looking at risk management and also risk communication. And we did talk about various measures for dampening down transmission, and the traditional ones were disease hygiene: stay at home if sick, wash your hands, cough and sneeze into a tissue or elbow. So these are all good, but they had real gaps for COVID-19 transmission, partly because a lot of people were infectious before they developed symptoms, so simply staying at home if you're sick wouldn't work very well, and also because it was transmitted with droplets and aerosols, coughing and sneezing into a tissue or elbow or just simply washing your hands wouldn't have reduced transmission that way. So that's why masks were really important, and we had the idea of mass masking or universal masking, which provides both source control and personal protection. I actually, for being a mask aficionado or zealot, I became immortalized on some mask packaging that was sold at Te Papa for a period. So one of the great revolutions in that first year was the development of multiple forms of effective vaccine. And these were, and you can see, in several different classes, including traditional protein subunit vaccines, these virus vectored vaccines, and this new generation of mRNA vaccines. There were initial uncertainties about how long would immunity last, would it stop transmission, and how would it go if the virus changed, if we got new variants. It turns out none of these vaccines were very good with managing risk in these three areas. So here's a question: what proportion of the population do we need to vaccinate to achieve population protection or herd immunity? And what is the parameter that drives this number? So this number is driven by, again, our friend, the basic reproduction number. So as the reproduction number goes up, the herd immunity threshold rises. So you can see for a disease like measles, which is the most infectious disease that really affects humans, reproduction number is way up here, 14 or 15, and the herd immunity threshold is approaching 95%. So if you get down to SARS in the early days, its reproduction number was about 2.5, and so you needed to vaccinate about 60% of the population. But later on it headed right up to maybe around 6 or more, heading towards 10, and so then you realize you had to vaccinate a lot more people. And so this is a very busy slide, but this is pointing out that you can calculate the herd immunity threshold with this simple formula: 1 minus 1 over the reproduction number. So for the original variant that had a reproduction number of about 2.5, using this formula it tells you that it's about 60%. But with the Delta and then Omicron, the reproduction number was moving up, so as a result the herd immunity threshold rose to quite a high level, 90% coverage. So you think, well, that's not too bad. We do manage that with measles vaccine, for instance. But you also have to look at vaccine effectiveness, and against Omicron with 3 doses, you've got about 70% effectiveness at stopping transmission. So already you're not going to get there with Omicron. And in addition, vaccine coverage with 3 doses was about 50%. And on top of that, and that gives you the effectiveness times the coverage, means that you've got about 35% effective coverage with the vaccine for Omicron, and has really got to be at 90%. And in fact, this is pointing out we can't vaccinate our way out of this, because even if you have 100% coverage, you're still not going to get there because the vaccine is just not effective enough. So if we're trying to measure the impact of a pandemic response and equity, how would you measure the success of your response? How would you measure equity? What are the sort of key indicators? Again, if you could write down what you think they'd be. So this is showing a paper we published after 100 days, pointing out that after the application of the control measures, we saw the cases drop and then basically stopped entirely. And the pandemic was halted in New Zealand for a period. And this is showing how different measures were phased in to do that. So this is really showing the curve right up to quite recently, earlier in 2024, and showing how we had these waves of infection from Omicron, and also they were mirrored in wastewater testing, although this is a less valid indicator now. This is showing hospitalizations, which also had these 5 peaks corresponding to pandemic waves, and deaths as well, and measured in 2 different ways. Again, showing these 5 waves over the 2 years that we've had widespread circulation of the Omicron variant. One of the things we're not measuring is long COVID, and we think this might be somewhere in the range of 10 to 20%, possibly a bit less than that, who have long-term effects. A number of ways of looking at the response or its impact. One is cumulative death rates, and you can see this is showing the cumulative COVID-19 deaths, and countries like Australia, New Zealand, Singapore that adopted elimination approaches kept mortality very low by keeping the virus out, gave time to roll out vaccines and prepare for the pandemic, and kept mortality low. We can look at another indicator which is even better, is cumulative excess mortality, and this shows that after almost 4 years of the pandemic, New Zealand still had around about 0 excess mortality, along with, we also had relatively low mortality in other countries pursuing elimination, much less than in countries where there was widespread transmission. And again, in that first year of the pandemic, New Zealand had positive gain in life expectancy, whereas a lot of countries saw at least 1 year of life expectancy lost, maybe even more. And after the second year of the pandemic, a global burden of disease report has come out showing that the pandemic resulted in a median loss of life across the globe of about 1.6 years. Now, nothing's done that since the 1918 flu pandemic. This is showing changes in economic activity over the pandemic period, and New Zealand performed above average for the OECD over this period. We can also look at the level of disruption. This is using a thing called the Oxford Stringency Index, and this is showing that index by day. And you can see that New Zealand overall maintained a low level of controls for the first 2 years of the pandemic, less than Sweden, UK and the US, for instance. And this is looking at the same thing in a slightly more quantitative way, and you can see across these first 2 years of the pandemic, New Zealand had this low stringency, and then by once Omicron was circulating, we essentially joined the rest of the world at this point. That's in 2022. So we can look at equity indicators again for these outcomes, and this is looking at hospitalizations and mortality, and these are age standardized. And you can see, unfortunately, that Maori and Pacific people had higher hospitalization and higher mortality than Asian and European populations. So that's an indication that we're not very successful at achieving equitable outcomes from the pandemic. This is showing one of the drivers of that lack of equity, the fact that there's lower coverage rates for Maori and Pacific people. So that is a real problem for our delivery of vaccines, and we need to learn from this and do better. We also have to think about unintended consequences of the pandemic and response. Things like, and one of them is anticipating adverse effects of interventions. So we can look at adverse event surveillance for the vaccine, evaluating the impact of, say, stay-at-home orders on things like school attendance, and look at the pressure on the health system from, say, deferred diagnoses and treatments. So our next question is about reducing the risk of cases and outbreaks. How can we reduce the risk of people getting COVID-19 within New Zealand, say if you're managing a healthcare setting? What are the risk factors for getting infected indoors? So if we look at the factors that contribute to your risk of infection, these are organism, host and environment factors. And we can't change much about the organism. We can change the host a little bit by vaccinating to improve immunity. So many of our controls are actually environmental. So looking at these areas in a bit more detail, this is showing how the virus has changed over time. Reproduction numbers increased, the incubation period has got shorter. And these are clearly adaptations which encourage or support more transmission, and so they give the virus a selective advantage, and so it makes more copies of itself, and so these characteristics become more common quite quickly. So this is natural selection happening. So looking at host factors, we're back to looking at Trump, and I remember being rung on the 2nd of October 2020 to say, by the New York Times, to say, Trump's got it, what's going to happen to him? And firstly, I was amazed they were ringing me, an epidemiologist in New Zealand. So I said, wow, his age is, he's in a higher risk group, and he's got elevated BMI, but he's probably going to get very good care and should survive. And of course, after the interview, I remembered that he was actually in a low income group based on his tax return, and also had precarious housing status because the election was about to happen, and he actually lost his the White House at that point. But if we look at the major risk factor for death, and this is showing the relationship with age, and it's on a log scale here, so this is showing that it's essentially an exponential function, an exponential rise in mortality risk. The last area, the third part, is as well as organism host, we've also got environmental factors, and we can think of what was pointed out early in the pandemic, the 3 C's of crowded places, close contact settings, and confined areas with poor ventilation. These 3 C's do drive the risk of transmission. Fortunately, they also correlate with a lot of places we enjoy going to, like pubs and restaurants and socializing, so and parties. So this is a problem for transmission of this virus. You might remember in the start of the Delta outbreak in Auckland, there was quite a lot of transmission in the Assembly of God Church, and that could only come from aerosol transmission, with around half the people there being infected in about an hour. So I think this is always quite a scary graph, and it's showing the probability of sharing a space with someone with COVID-19, and that's a function of the population prevalence along here, and also the number of people in that room. And this is a spot I've marked up here where, say, you've got 100 people and a fairly slightly elevated prevalence for what we're seeing at the moment, but not unusual for current peaks. So if we're about 1% there and we've got about 100 people, you can see that you've got about 20% chance maybe that you're sharing the space with someone else who has the virus. This is showing about how the virus is mainly thought to be transmitted as an aerosol. There's less concern about fomites, that's contaminated surfaces. And this is a framework for looking at the hierarchy of controls that you can eliminate threats. We've got engineering, administrative controls, such as ventilation or encouraging, really promoting working from home if you have any potential symptoms. And really at the bottom of the list is PPE. This is really an essential tool, but it's not necessarily the most effective tool we have. And this is looking more at the area of ventilation and the need for legislation to ensure a safe standard of indoor air quality in public settings. And you can also take these CO2 monitors and measure the level of CO2 as an indicator of how much rebreathing is going on. And again, mask use. Masks really come into their own as source control as well as personal protection. To the point where if you're wearing a high performing respirator style mask, you've both got them on, you can talk to someone with COVID-19 perhaps for an hour with a minimal risk of you getting infected if they're wearing a mask and you're wearing a mask. So our next question is around using testing to control COVID-19. So you've got a rapid antigen test. Would it be useful for screening patients in the hospital emergency department who are attending for non-COVID conditions such as injuries or childbirth? Assume sensitivity of 80%, specificity is high, 98%. Got a couple of scenarios: quite high prevalence or relatively low prevalence of 1%. So here we are with prevalence of 10%. Applying this test, you identify 8 out of the 10 cases who were infected, and you could isolate them so they didn't infect other patients. You'd falsely identify 2 people as positive who were not. That wouldn't be a problem. You could then apply a more sensitive test like a PCR to work out if they were reinfected. You'd still miss a couple of people, which would be a problem because they would be treated as though they were not infected and could potentially infect other people. So the other scenario, 1% prevalence. So you'd pick up that 1% in this case. You'd still have a couple of false positives and you wouldn't have missed anyone. So it's still a question mark about whether to use testing. Probably with relatively high prevalence like 10% you would. So looking again at another use of testing, this is to see if people are okay to go back to work. Now, one of the things that's with this virus is you are often infectious for up to 10 days. And even at 5 days, around 2/3 of people are still shedding the virus. So a test can be very useful at that stage to see if it's okay to go back to work. Even at 7 days, around 1/4 of people are shedding the virus. So rapid antigen tests are useful for detecting whether you still need to be isolating or not. So now we're talking about using information and combating misinformation. So what is the difference between these two? Why does it matter? And what should we do about it? These are not necessarily easy questions. So misinformation is all around us. We have it in our own heads. This is false information that is spread, and we don't really intend to mislead. Disinformation is the added component that there is intent in this situation. So we saw a lot of misinformation, disinformation at the Parliament occupation. This group of women were interesting because they were wearing these aluminium foil hats or to protect themselves from radiation coming out of the beehive, and they were explaining they had to leave because they'd stripped the local supermarket of all its aluminium foil, and so they were concerned they wouldn't have protection shortly. So this is illustrating why misinformation, disinformation is so important. If we use a framework like the health belief model, which basically is a cognitive framework, and if we look at its role, say, in supporting a behavior like vaccination, you believe you're susceptible to the virus, that it can be serious. There are benefits of having the vaccination that exceed the costs. You don't see any significant barriers to acting. You're regularly reminded to act. And self-efficacy is the idea you feel confident that you can carry out this action. So misinformation, or particularly disinformation, damage this chain of beliefs at multiple points. If you believe COVID is a mild illness or it's fake, that vaccination is ineffective and possibly dangerous, and so on, this disinformation really is going to get in the way of you getting vaccinated. We know that this disinformation comes from a range of sources, some political sources, some news media, and some global programs such as the Great Barrington Declaration and an offshoot in New Zealand, the COVID Plan B. So I think the quality of public information in New Zealand was very good during the pandemic, particularly during the elimination strategy, and of course we saw the messaging change as the pandemic progressed. One thing about being a COVID commentator is you're just saying the same things over and over again to the point where you're starting to bore yourself. And I love this statement, a public health triumph, nothing happened. And this is saying that it can be quite hard to continually alert people to things that, if you're successful, won't happen, because they may well turn around and say, what was all the fuss about with a pandemic, for instance? This is another area where I have thought about the framing of communication, and this was saying one of the benefits of mask wearing, it not only protects you, but also protects others. And there's not that many things that do both. Say not smoking indoors, for example, is protecting you and other people around you. And a lot of things on the roads also are protecting you as a driver and also other people, other road users. But a lot of other interventions either just protect others, such as you self-isolating, or maybe largely protect you. That's vaccination, for instance. So we set up a new public health communication centre, which again is trying to increase the volume of correct evidence-informed knowledge. And you can actually sign up to get our regular briefing articles. If you're interested, you can just go on the website. And the price is right, it costs nothing. So one of the things I've become aware of is that there is a need to protect the messenger, and I have encountered quite a few examples of pushback from the anti-vaccine lobby and also those groups that think we overreacted to the pandemic. I had one funny, well, moderately amusing experience of having being impersonated online and with a fake Twitter account for about a year, which we couldn't get removed. And this person would make various statements and sound slightly like me in their written content, but would also include quite a bit of disinformation. So planning for future scenarios, how will the pandemic end and how will we know when we get there? Well, COVID-19, there's several possible trajectories. It could become an endemic disease like the common cold, and there are other 4 endemic coronaviruses already are a common cause of the cold. It could carry on as an endemic infection like seasonal influenza. It appears to be more severe at the moment than the flu, which is still, in the past, was our single biggest infectious disease killer before COVID-19. or we could have a continuing pandemic. That is, that the virus keeps mutating in ways that stay ahead of our immune response, and it might even have some big leaps in its evolution, as we saw with Omicron. So thinking about future scenarios, the pandemic ends when this virus becomes a relatively predictable endemic threat. It doesn't mean it's necessarily mild, or if we could eliminate transmission for prolonged periods, which we can't do yet, although with a very effective vaccine we could. The World Health Organization doesn't declare pandemics. They only declare public health emergencies of international concern. They've already said that that has ceased to require an emergency response. Other writers talk about medical, political and social ends to pandemics, and these may come at different times. A major factor in the pandemic is how the virus continues to evolve, and this is tracked quite closely in terms of the succession of different subvariants of Omicron at the moment, and we may see a whole new variant in the future, but we are seeing these big sprints in virus evolution. So what are some of the lessons for improving public health? So perhaps again pause for a moment to think, what are the lessons and opportunities from this pandemic for better managing other public health threats in the future? Do you see, is there a silver lining? I mean, it's quite hard to see the silver lining, but we really have to try and extract as many key lessons as we can from this episode, because it's been so costly in terms of human lives and in many other aspects of our lives. So I'm going to talk about these 5 areas very, very quickly. The idea of improving evidence-informed decision making, adapting the response to future threats, building public health and science infrastructure, supporting effective global health institutions, and also seizing public health opportunities provided by the pandemic. So one of the things that I've learned is just the critical importance of effective science plus good political leadership. This is a great combination, and that's what we saw in New Zealand. Again, I think elimination or exclusion is certainly easier and less disruptive if measures are started early in a pandemic. So it's good to identify scenarios in advance, and certainly we saw that in New Zealand, that by going very early with our elimination strategy, it was very effective. We have to also think about the kind of threats that we're going to see in the future that we might want to apply this approach to, and this is looking at going from a relatively low case fatality risk to high case fatality and low to high transmissibility. And these are the kind of conditions that we see in this box here: seasonal flu, smallpox, emerging disease X, which is just another way of talking about spillover infections from animal reservoirs, and the potential for novel synthetic bioweapons. Of course, we're thinking about our public health infrastructure. This is the structure we have at the moment. It will be undergoing more changes shortly, but we have now a public health agency as part of the Ministry of Health, and we have a National Public Health Service as part of Te Whatu Ora, and again that should give more consistency and delivery capacity across the country. So these are positive advances, although there are other aspects of the new structure that are probably more controversial. So it's a very busy slide, but it's saying that a lot of science advanced during the pandemic in terms of disease modelling, surveillance, and molecular biology, whole genome sequencing, and so on. So these were really good advances. We know at the global level we need to improve our institutions, and of course the independent review panel that is being co-chaired by Helen Clark has also been a big advocate for better capacity to manage future pandemics. And some of the things we do, regardless of where this pandemic came from, it does need a better global response. I mean, it's almost always very likely that COVID-19 was a spillover infection from animal reservoirs, from bat reservoirs in fact. Wet markets may have been involved in its proliferation, but we also have to think about laboratory escape, which I think is very unlikely in this instance, but laboratories have been the source of previous outbreaks, so we do need to regulate them closely, particularly if they have a high level of or high containment of serious pathogens. We have recommended that in future the World Health Organization assigns a response strategy for new health emergencies, and that it should be an elimination strategy as the default option, because that offers benefits in terms of delaying spread and ideally eliminating its source. Hopefully there are opportunities for more transformational changes in other areas in terms of a green recovery and a more equitable society. This is obviously depends on willing governments and good international collaboration. So in summary, it's critical to use an evidence-informed strategy for responding to public health threats like COVID-19. COVID-19, I think, is a further reminder of just how important equity is in policy and practice. We do need to prepare for far more serious catastrophic risks than COVID-19, including other pandemics, climate disruption, and growing inequality. One of the best things we can do is to invest in public health and science infrastructure to give us greater resilience at the national and global level. And I think finding better ways of communicating and managing disinformation is really important, particularly to maintain public trust in what we're doing. I just want to acknowledge the fact that I've been working with a large and talented group of colleagues throughout the pandemic. And finally, a use for the flag debate. Thanks.